Thank you very much. So I'm really here to talk about this issue that I learned and what I learned as Director of Public Health around engaging with our population. What did I learn from the COVID pandemic? So first of all, I'd say there is no better place to address the questions that you are talking about than in Leicester. There's no better place than to pick up the learning, the knowledge, the experiences than Leicester. So let me just make sure we've got this working. Wonderful. So I know that you are going to have a lot of slides today. So I am being kind to you. This is my only slide. One slide. I am not responsible for slide fatigue that you may experience later. So this is my one slide, and this is Leicester. Where we're looking at this is around ethnicity across the city. You'll see some really interesting patterns here. So if you look to the west of the city, you'll see that that's the strength of that's where our BAME population predominantly is. In the east of the city, in the west of the city, you'll find our traditional white working class. We're quite a deprived city in the sense of economically, but I always say we are maybe economically deprived, but we are socially very rich. But we are a real growing city. So we've got a population here in the city of about 368,000, just over that. But we are growing rapidly. So if you were looking between 2021 and 2011 and 2021, we saw almost a 12% growth in our population compared to the national picture of around 6.5%, 6.6% for England as a whole. So we're growing faster than most places. We have a very complex population. We have a very young population. The majority of our population is between 0 and 44 years old. So when people are talking about aging populations, unless we're really talking about a very young population. And in that younger populations, there's a greater cohort of that population that are from a BAME background. We've got a lot of geographical divides. You can see the picture there. So not only around ethnicity, but around deprivation, around a whole load of different factors, which means that our city is quite complex. We can't do it in one way. We have to do it in many, many different ways. I used to talk to my other DPH colleagues, and when they were putting in an intervention, I'd say the difference between you and me is you will do it once or twice, and I will probably have to do it 60 or 70 times to have the same effect because of the nature of the population in which we serve. So, as was said, so we are the first plural city. So we're thinking that 60% of our population is non-white. But there are other cities. Those of you that are from Birmingham know that you're not far behind. You're 51%, Luton 55%. Newham keep piping up and keep saying, oh, no, but we are 69%. And I keep saying, you're a borough, you're not a city. So it's still a Leicester thing. But also, we're on the other side of that, where we, as Richard said, we serve a broad population. So we also have our county and Rutland. It's completely different. So within the county, we have 88% of our county residents are white. In Rutland, 95% of them are white. So when we are serving, and we spoke about our research institutions, we have to think of all of those and being applicable to all of those and making interventions that relate to all of those different areas, real changes that exist. I think what I'm really trying to point to you is that inclusion for us, inclusion if you're working here in Leicester, Leicestershire or Rutland, is not a nice to have. It's an absolute essential. We cannot do our work, we cannot be effective, we cannot do anything that is considered valid if we are not grappling with the whole concept of inclusion. So the question is, how do we do it? What do we do, particularly with populations like ours that are so diverse? So there's some learning that I got from the pandemic, and it really reinforced that challenge. As was said, we needed, being the first that were put into a local lockdown, we needed to find new ways, relevant ways, as a matter of urgency, to relate to our entire population. I think across the country, Director of Public Health learned that they needed to communicate very, very effectively with people. They learned that they needed to make sure that what they said or what they were advocating reached everybody. And we used to say that we did it, but the reality is we didn't do it. We didn't do it that well. As long as we had the majority, we felt that we were all right. That is no longer the case. We had to do so much more than that. So we had to learn new ways. So I'm going to share with you probably about 4 or 5 things that I learned from that situation. The first thing that I would say in terms of effective engagement with our communities, effective ways of learning. If you remember one thing that I have said when I've been here, this is it. It starts with trust. And I know a lot of people are talking about that, but genuinely, it starts with trust. Everything stems from there. And I can't emphasize that enough. Many of us, we are trying to do the right thing. But in many of our communities, lots of us as health professionals or workers still come with low levels of trust within our communities. We consider ourselves to be anchor institutions, but often people are still very, very wary of where we are and where we're coming from and what we want. And I say that as somebody who was born in this city. I come from a minority community. My parents were that kind of Windrush. My mum worked as a nurse across the road for many, many years. My wife's a GP. I was born here. I was educated. And yet I still had to work around issues of trust within the community. Things like representation. I am going to say it in this room. Representation remains an important issue. As we look around us as research, we've got to really make sure that when we are talking about inclusivity, we're starting at home. Making sure that our research teams look like the populations that we are trying to serve is incredibly important. Bringing those people through, supporting them, because that will help us to get better results in the things that we want to do within our communities. So the first thing that I learned that was really, really important is, number one, please listen. Don't start by talking, start by listening. Now, as we said, it's the election here today, and when I'm listening to all of the vox pops that are going and people are talking about different elements, some of those statements that I heard, people are saying, well, I'm just not interested in what they have to say. They might say things like, they don't really care about me, they only want me when they want something. They might say, I don't trust them, they've broken so many promises in the past. Or they only look after themselves, and it's tokenism when they come to me. They're not interested in the things that I'm interested in. And these are all things that may have been raised at political parties, but I then ask myself, are these questions that are actually raised about us? Are these questions that are raised when we go out and do research or provide services? Are not those same accusations coming forward to us? So I recognize those statements because when we were trying to go out and do vaccination programs or engage people around the idea of contact tracing or whatever it was, those same nuggets of information, those same pushbacks came back to me. So the one that really got to me, and remember, I know lots of people in the community, and I remember sitting on one of the ubiquitous Zoom calls. Kamlesh was with me as well. And we were on many of these Zoom calls where we had, maybe 1,000 people on as well. And we're talking to them about the importance of vaccination, the importance of what it is for the community. And I remember one where somebody said, yeah, that's great, Ivan, but where were you when I needed you about something that's really important to my community? Where were you when I wanted to talk to you about mental health? Where were you when I wanted to talk to you about my concerns about vaping or the use of drugs in our young community? But you come to find me when you want me to be vaccinated. That really struck a chord with me. It really changed my practice. And also, that meant that I had to I realized that certain things that I have to do first before I can start to have conversations with people about what may be my requirements. So I learned the importance of listening. We developed community champions, networks that allowed us to just listen better. The other thing that I realize is that we have got to learn to adapt. So very often we have our spreadsheet of the things that we want to do, and the communities are saying, well, that might be fine for you, but actually that doesn't quite work for us. So I learned the importance around adaptation. So we used to do things in a certain way, and I realized that if we start listening to our communities, we start thinking about our communities, we can find better ways of doing things. Often the answers sit within our communities. We don't have to go and find them. And we need to be sensitive to the needs of our communities from our different backgrounds. I remember having the devil's own battle around consent forms. Consent forms, we want your children to be vaccinated. We had a consent form that must have run for about 5 pages. It was so dense that nobody could sign. So we just went back and said, can we just simplify this? Can we just make it in such a way? And really the consent form was not so much around the people being informed, it was about making sure that we were covered. We have to rethink the way that we do things. We have to think about what is the goal that we're trying to get to here. So that was really important. The other part that I think was incredibly important is that we need to think and act as if we are part of the community and not just the institution that we're coming from. So when we were going out and people saying, well, I really need to have a conversation about this, I needed to take that on board. And certainly some of the things that I did was saying, I can't do this today, but what I can do is promise you that I'm going to come back and have a conversation about this. What I can do is say, the knowledge that I have, I will help you to navigate so that we can have that conversation about this thing that concerns you, because I am part of this community and I want the concerns of this community to be part of the things that we do for you. So I really had a conversation around that and started to think that I, as a worker in the community, am actually part of the community, not just part of the council or the local authority or the NHS. My other point that I think that I also picked up was the importance around innovation. Doing things in different ways. Not being afraid to do things in different ways. COVID forced us to do things very, very rapidly. Change. It was action research, amplified. And we would find ourselves, for example, I know that before we used to have the mobile vehicles that used to come and we used to test, and we were saying, no, let's go into community centres. Let's put a mobile testing unit on a park. Let's go to where the people are. The resistance to be able to do that was tremendous. But actually, when we did it, people came. We had a real challenge once with our Somalian community, where the figures that we were having, we were collecting the data, and the figures kept saying that you have a community there that is not being vaccinated. And it's almost like it's their problem. We need to talk to them more about it. We had a medic who was a Somalian community. She said, no, that's not the problem. The problem is you have located your vaccination centre across the road. And as far as we're concerned, across the road is a completely different community. It's 500 yards. The other thing is, it's in a centre that's not a centre that we recognise. So leave it with me, let me help you. We redid that vaccination centre in a mosque with the greeters from the Somalian community, even though it was still us delivering it. And within the space of 2 weeks, we went from something like 20% coverage to 65% coverage. And the interesting thing was, it wasn't just the Somalian community that came, it was all of the local community that came. So, the white working class were more comfortable coming there and being in the mosque with the community than crossing the road. We just had to change things up, and we just had to listen and be able to do those things. And the other thing that I wanted to just finally say was that partnership was vital. Nobody can deliver what we want, what we need to deliver by doing it on our own. I learned that certainly as a public health leader, that much of the work that was done well outside of my team. It was done with university, it was done with businesses, it was done with academics, it was done with clinical, it was done with so many different communities. So how do we build in partnership, meaningful partnership with some of our communities? We have set up memorandums of understanding when it comes to research. So we don't go to the community and say, we are now interested in doing some research on X. What we do is we go to the community and say, how can we work together on things that are important to you and things that are important to us? So that means that now sometimes they will come to us and say, we've got a real concern about this in our community. Is there any research that's going on that you're aware of that we can be involved with? And the opposite way around, sometimes research will say, we want to do this. Can you be a gatekeeper? Can you help us with that? How do we build up those meaningful partnerships with our communities? Because when people say that our communities are hard to reach, I still don't believe that's true. I think we are still very easy to ignore. But the thing is that we need to change, and we need to adapt, and we need to grow. So when I looked at some of the objectives that it said for the CRF, it spoke about the importance of operational delivery, strategic leadership, workforce development, involvement and inclusion. It's no surprise to me that we have chosen this topic area, because if we can get inclusion right, if we can engage with our communities more, we will develop that sharing and implementing of best practice. And we will be able to build strategic partnerships. We will be able to meet the needs of evolving workforces, and we will be able to improve patient experiences in study and design. All those things that we said really are critical to the agenda that we're talking about today. So thank you for your time, and I hope that you have a great conference. I've got time for questions, if there are any. I'm being pointed at here. But if there's any things that people want to have a conversation about, I'm more than happy to answer any questions.
So we only have time for one, I'm afraid, so I'm sorry about that. But thank you for sending your questions in. And thank you for a very interesting talk. Do you have any more advice on tackling misinformation, e.g. COVID vaccinations?
Wow.
It's a big question.
So, big question. Misinformation within our communities was huge. And what we ended up having to do was understand that when we're talking about working with our communities, it is not blanket bombing. We cannot use, we will have a national campaign. We cannot use one-size information. So what we ended up doing was actually going to communities. Our communities come from very much an oral tradition. We want to see your face, and we want to ask you a question. So I cannot say, Cameron, I don't know how many, I'm not sure how many Zoom calls we did. But we did Zoom meetings night after night after night after night with trusted people. And whether it was a small church group to, the entire register of a multiple GP practice, we were there to answer the questions. That was by far the most effective way of dealing with misinformation. Because what you've got to realize, those individuals that were on that call then went off and spoke to their families and their friends. It's understanding how community operates. You're not just talking to that person. If you get the mom or the auntie in that room when you're answering that question, you've got everybody. You've got everyone. And so that became the drip, drip, drip effect. And that's what kind of turned the tide for us in terms of misinformation. And I heard people coming back, literally in my ear, heard people coming back and saying, I heard this nonsense that came down the phone. I told them what you said to us about X, Y, and Z. But again, going back to my point that I started off with, why was that possible? It was because before COVID hit, they already trusted us, or we built that trust in place. So that was pretty key.
Thank you very much.
Thank you.